Can get started now. So we'll get started. Introductions and we should probably at least introduce the board members. Let's just so other folks know who we are. So I'm Rick Trelevin. I'm CEO of Best Care Treatment Services, and I'm the chair. And Linda, who are you?
Linda Johnson. I'm a community rep on the Health Council, and I'm the vice chair.
Great. And I'm just going down the list. Commissioner Dare, who are you? Well, that's Commissioner Dare, who's trying to get off mute, which
I'm off mute now. Sorry about
Okay.
that. Yes.
I'm always worried when elected officials can't get themselves off mute. It seems a little concerning. So anyways, who are you? She's Commissioner of Deschutes County. Is Eric part of us? No. Gary Allen, I think, is out today. Paul Andrews, who are you?
Hi there, Paul Andrews, Superintendent of the High Desert Education Service District.
Thank you. Tammy Bainey, who are you?
Hi there, Tammy Bainey, Executive Director of COIC. Great to see everyone.
Good to see you. Megan Hayes, who are you?
Hi, Megan Hayes, Mosaic Medical.
Thank you. Brad Porterfield, who are you?
Hi folks, Brad Porterfield. I'm the consumer representative and the Community Advisory Council chair.
Okay, thank you very much. Divya Sharma, who are you?
Divya Sharma, Chief Medical Officer for Central Oregon IPA and practicing internist at Lapine Community Health Center.
Thank you. Justin, who are you?
Justin Civil, I'm with Summit Health.
Great. Iman, who are you?
Iman Simmons, St. Charles Health System.
And Dan, who are you?
I am Dan, Dan Stevens. Good to see everybody with Pacific Source.
Okay, thank you. And everyone else is visiting. Just these meetings get so large. Oh, we should introduce the healthcare staff. Donna Mills, who are you?
Good afternoon, everyone. I'm Donna Mills. I serve as the Executive Director of the Central Oregon Health Council.
And Kelsey?
Hi, everyone. I'm Kelsey Seymour. I am, for the next 5 weeks, the Administrative Assistant and Media Coordinator at the Central Oregon Health Council. I want to introduce my successor, Camille Smith, next. Camille, do you want to introduce yourself?
I'm Camille Smith. I'll be stepping into Kelsey's shoes in 5 weeks.
Well, slowly.
Okay, hold on.
During that.
This is not a good meeting so far. Kelsey, what is going on? I'm sure I'm going to love you, Camille, but what is going on?
Just so we're clear, no one in this room poached me. I am leaving healthcare altogether. There would be blood at this meeting from Donna if anybody had hired me. No, I'm going to start my own business in the writing and publishing industry. It's been 5 years at the Health Council, and it's been incredible, and I've learned so much. So thank you all for being a part of that. And I will be around at the September retreat. So not retreat, combined meeting with the Community Advisory Council. And that's probably the last time I'll see you all in this capacity.
Congratulations.
Thanks.
Okay, well, we know the whole system will fall apart without her. So we're working on that and grieving. Renee, who are you?
Hi, everyone. Renee Worth, one of the project managers with the Central Oregon Health Council, and you are stuck with me.
And Michaela.
Good afternoon, everyone. Michaela Arsenault, one of the other project managers at the Central Oregon Health Council, and my pronouns are she, her, and hers.
Great. And Gwen.
Gwen Jones, she, her, hers, also project manager.
So we have a few guests. I'll go through them that I see. If I miss you, then my apologies and just speak up. Tricia.
Hi, good afternoon, everybody. I am going to do my best to be the new Leslie in this space as the new director of the Central Oregon CCO. Leslie will be moving into a role where she's overseeing all of Pacific Source's CCO work. So thank you very much for having me. And I know Leslie will be joining us soon.
So Tricia, I have a warning. You always want to follow a failure and not the superstar, you know, when you start in a new job. So a tough
Camille
road
and
to hoe.
I are in trouble.
Yeah, tough road to hoe. That's all I gotta say. Sarah Holloway.
Yes, Sarah Holloway from Pacific Source. I'm the care management manager for the Gorge region, Central Oregon, and Portland.
Great, thank you. Erin Fair-Taylor.
Good afternoon. I'm Erin Fair-Taylor, the Vice President of Medicaid Programs. So I'm also following a tough act. I'm stepping into Lindsay Hopper's former role as she stepped into a greater leadership role at Pacific Source. So Tricia and Camille, we can all share.
Commiserate. I seriously encourage commiseration. Okay, Rebecca Donald.
Hi, thanks. I'm Rebecca Donnell. Pronouns she, her, and hers. And I'm the innovator agent with the Oregon Health Authority, working with Pacific Source CCOs and Trillium.
Great. Kristen Tobias.
Hi, I'm Kristen Tobias. I am the community health coordinator for the Central Oregon CCO.
Just so you know, I do have a name that's totally mispronounced by everyone also. So my apologies right
No,
up
it's
there.
okay.
Andrea.
Good afternoon, everyone. Andrea Kettlehead. I am the Quality Incentive Measure Program Manager for Pacific Source.
Great. Kelly.
Good afternoon, everyone. I'm Kelly DeVore. I'm the new director of the CCO in Lane County. So I'm just listening in to learn.
Okay. Kim. No.
Sorry about that. Kim Bangeter, CEO at Central Oregon IPA.
Great, thank you. And Sarah?
Yeah, if this is, I don't know if there's another Sarah, but I'm Sarah Mosier. I am the Pediatric Population Health and Clinical Quality Manager over at Central Oregon Pediatrics.
Great. And the last one is Catherine Ryan.
Hi there, can you hear me?
Yeah.
Hello. Okay, thank you. I'm on the phone. So I'm Catherine. I'm the new community health coordinator for the Lane region. So working with Kelly and just listening in. Thanks.
Okay, great. Thank you very much. So I hope that everyone has had a chance to review the action items and the agenda and the consent agenda. Can I have either a motion to pull one of those off or to approve the action items and consent agenda?
So moved.
Can I have a second, please?
Second.
Okay, all in favor, say aye. Or signal some way. Or if you're not saying anything, we'll assume it's correct. Okay, Dr. Andrews. Okay, you have the patient story.
I do, thank you. So I hope it's okay to do something a little bit different this month. In our education world, we a couple years ago recall that this board approved the funding of the Culture of Care program for Better Together, representing all the school districts in the Tri-County region. And High Desert ESD hired 3 care coaches as a result of that. And I wanted to just share a little bit about some of the work they did this past year. So one of the first presentations that the care coaches were asked to do by the director of special education in the Crook County School District, so over in Prineville. She reached out to the team to provide some professional development to her educational assistants serving children with special needs. One of the topics presented to the participants was Michael Grinder's Influence to Power Continuum, which is called the Envoy curriculum, teaching the mindful and purposeful use of nonverbal communication skills to begin with an influence approach and using small steps into power as needed when managing students. The special ed director was so pleased with the feedback from the training, and the care coaches were able to engage in a deeper discussion with the Crook County School District leadership and introduce them to the full Envoy approach for systematic classroom and student management. The model increases predictability for staff and students alike, as well as providing teachers reduced frustration and increased time for academic teaching. While the district leadership was absolutely interested in implementing it, they required patience and engagement with the Regional Educator Network, another funding source in our region that is also based out of the ESD, to make funding the opportunity a reality. In an effort to build a sustainable implementation plan for implementing Envoy, the Crook County School District reached out to one of our Culture of Care coaches, Erin Taylor, not to be confused with Erin Fair Taylor, apparently. And she visited Steens Pillar Elementary School to provide some opportunities to teachers to have her observe students, provide some tips for more effective management of students in their environments. In a kindergarten class, one student was seated apart from the class and was showing outward signs of dysregulation. When an educational assistant came into the room to support that student, she brought very high energy and lots of enthusiasm, as well as lots of words. The professional was absolutely well-intentioned and strongly desired to help. Seeing an opportunity, Erin was able to provide a step-by-step approach through her coaching that included giving the student space, cueing the student to work by calling the student's name from a distance, and cueing the student to the desired task non-verbally, as well as providing encouragement. When the student picked up the pencil and began writing, the adult saw the power of influence approach and could not wait to learn more. The care coaches are currently collaborating with the Regional Educator Network and Crook County to support Envoy training for all leaders, teachers, and educational assistants prior to beginning this school year, as well as train district Envoy coaches to provide ongoing coaching for this new learning to ensure strong implementation. So again, not specifically about a quote patient. We don't think of patients within the world of education, but want to link it to the work that we funded the care coaches, and they're in year 3 right now, starting year 3 of supporting all of our districts in thinking differently in a trauma-informed mindset and different ways of working with children. So hope that gave you some illustration of that.
It's actually really huge. I mean, that kind of impact is just huge. I really appreciate that story. Any other comments about that? And I had skipped over public comment. Is there anyone from the public who wants to comment? And if I'm missing you, not everyone gets into the Hollywood squares of my screen. So just please jump in and don't be overly polite. Okay, thank you. So the next piece of discussion, we're gonna be led by, start off with Iman, but there really, I think we've all are aware of how much the rise of the Delta variant is really impacting our services, our staff, our own levels of frustration. And so I think Donna suggested, after some discussions, that we have a discussion on the impact of the Delta variant on the Central Oregon health ecosystem. And I know that about 2 weeks ago, I had well-developed plans for opening up the agency. And in behavioral health, it's in-person contact is a big deal. And that just had to get tossed out the window and just watch those outcomes continue to be crappy. And so we're all trying to manage this. So so this just seemed like a very, very big topic that would be useful for all of us to participate in and maybe develop some collective response to. So Iman, lead us off.
Thank you, Rick. And I had prepared a few slides just to kind of share some of the current challenges that we're experiencing at St. Charles. And then what I shared with Donna and Rick, I hope to have some engaging dialogue after I go through the slides. Renee, would you be able to put it into slide presentation? And I also just want to welcome Dr. Jeff Absalon, who's our Chief Physician Executive at St. Charles, who can join in on the discussion. And then I think that Joan Ching is going to be able to join us. She is our Chief Nursing Executive at St. Charles, and she joined us earlier this spring. So she's been jumping in and helping with all manner of patient care flow and nursing development. The one thing I wanted to contextualize in this discussion is that it's not so much just the rise of the Delta variant that's kind of causing additional challenges right now. I think what's honestly the biggest problem, and I would like for the board and guests to engage in this conversation, I think it's just the duration of this going on. We're now hitting our 18th month of dealing with a global pandemic. And I think healthcare, not only just in Central Oregon, but I think across the state and the country, is at a tipping point that's pretty serious. And so some of the issues I'm going to point out are not unique to St. Charles, but I think that it very much represents the state of healthcare in the United States. Next slide, Renee. So this is just a quick orientation to positive COVID-19 cases in our Central Oregon region. You can see these peaks and they very much correspond with hospitalizations. We are experiencing over on the right side this dramatic increase in cases, and that is attributed to the highly contagious Delta variant. Next slide. In a nutshell, what our problem is around this is that 66% of our eligible population is vaccinated. With the Delta variant, the science tells us that we need about 85% of our eligible population to be vaccinated in order to be more protected. And we are clearly not there. Next slide. So this is the run chart that illustrates our surges in the past that very much probably correspond in your mind with that previous slide of positive test cases. We are experiencing our fifth surge of COVID-19. As of this morning at 10:30, we have 34 hospitalized COVID patients. And we anticipate that this surge is going to bring us up to around 55 inpatients. And that's with interventions. The modeling includes the interventions of masking, which we are probably all aware that the governor's order goes into effect tomorrow for indoor masking. So it could be worse than 55 patients if our community does not adhere to the masking guidelines and the physical distancing that we're all familiar with and probably very tired of. And again, just wanted to contextualize that we're not alone in this. Our kind of sister hospital down in the Medford area, where their vaccination rates are even lower than our Tri-County area, they're having about 119 cases as of earlier this week. And they only have about 10 more adult beds, hospital beds, than our system. So they're really struggling right now. Just, I think yesterday we were asked and were able to do this, which is share some ventilators with Asante. So we're doing some regional sharing of resources, and it's all of this just to contextualize for you. Again, this has been going on for 18 months. So people are very tired. Quite honestly, at a point of our workforce at a breaking point. Next slide. So again, just to contextualize, what are the hospital bed resources that we have at our disposal? So we have St. Charles has 4 hospitals for a total of 275 adult critical and acute care bed capacity. We have the ability to surge up to 20% above that if we have the workforce. Next slide. So part of the challenge around bed utilization and the constriction of our patient flow is ED utilization is up. If you look between July of 2020 and July of 2021, we're experiencing about 1,500 additional ED visits per month. And that is really a stress on our system. People are coming into the emergency department after months now of delayed care. They're coming in sicker and with not COVID-19 disease, but coming in with delayed care around cardiovascular disease, metabolic disease like diabetes, gastrointestinal, and they're having to be admitted. And so our available beds for other services that are also critical to our community, like elective surgeries, get crunched when you have this influx of admissions through the emergency department. You can see also that top purple bar is what are called ESI or acuity level 4s and 5s. And keep that in your mind that that chunk is very appropriate for urgent care or immediate care within your primary care. So if we could peel off 1,000 visits by having our community step up for urgent care and same day primary care, that would be of tremendous help to our emergency departments and to our overall hospital system. Next slide. So the Delta is just another ugly element to this continued problem. It's very contagious. It now represents about 80% of our new US COVID positive cases. It's very much in Oregon and in Central Oregon. And unvaccinated people are at significant more risk of transmission, although we are seeing, and you're probably seeing in the media and the news, that the vaccinated are having breakthrough cases related to this. I have to say that still, the majority of those that are hospitalized for COVID-19 disease in our St. Charles system are unvaccinated. Next slide. So we have our patient flow challenges. We're having an increase in traumas, about 30% that need to come in through our emergency department and have immediate services provided. We have a group of people that are small, but yet contribute to a large proportion of our emergency department utilization. So 42 patients over the last 18 months are contributing to over 1,400 visits. And we as a community need to wrap around them and provide a lot of, I think, support for the social determinants of health. I think behavioral health, substance use disorder, housing, etc., because they will end up utilizing the emergency department. I don't know that we're helping them get better and healthier. We're just trying to create some sense of stabilization. Next slide. So our overall hospital length of stay has gone up by almost a day between 2019 and 2021. And this is also contributing to our inpatient flow challenges. People, again, are coming in through the emergency department, being hospitalized, and they are sicker. Our hypothesis is because of delayed care on the outpatient basis. And then also they're coming in with a lot of complex social needs. And so they're having what are called, patient placement challenges. So on any given day, we have anywhere between 30 and 45 patients that no longer need to be in the hospital, but are waiting for a bed in the community, whether it's a SNF bed or an adult living facility bed or a memory care bed, etc. So as much as we can as a community, rally around ensuring that those services are available and appropriately staffed. That's something that I think would be an amazing point of advocacy for the Central Oregon Health Council. Next slide. So we have staffing challenges like everyone else in Central Oregon and across the country. We need 600 nurses to take care of the patients in our facilities. Currently, about 30% of our workforce is missing. They're either vacant positions or they're on leave and not in their usual assignments. And it's causing a real challenge. Next slide. I'm not going to go through all of this. You can kind of look at it and absorb it. And none of it, I think, will be shocking to you, but it is hard to recruit healthcare workers right now, particularly RNs. It's highly competitive. We are getting what are called traveler nurses to come and work for St. Charles for like 6, 10-month or 10-week assignments. It's extraordinarily expensive. They're not part of our permanent workforce, so it feels disjointed in many ways, and it's not healthy. And I would say that it's not healthy for the United States, not just for Oregon and Central Oregon. You can see there that we are going to be needing in about 5 years 2 million RNs, and our current educational system is producing about 500,000. So there's a huge disconnect between what is needed in healthcare to run effectively and safely and what we're actually producing. And then we all know this, but it is very, St. Charles is at the sharp end of this. It's hard to recruit people to live in our region. Either, if you want to live in Prineville, you can't even find a house or an apartment to rent. You might be able to find a house or apartment to rent in Bend, but it is extraordinarily expensive. And we have very, very real and sad stories of people having to move from the region because the house they were renting for the last 3 or 4 years is being sold and they can't find anything equivalent. And so people are literally having to move away. And who's moving away? An emergency department nurse. So it's just this compounding problem of affordable housing, affordable and available childcare, with an overall workforce shortage. Next slide. So what are we doing about this? We're getting creative. We're sometimes feeling desperate, which does enable innovation. So we are thinking of different things out of the box, countermeasures to address this problem. One of the things that we just started last week was to develop a business agreement with Bend Transitional Center, and we are sending St. Charles CNAs to staff beds so that we can improve the patient flow for the patients that don't need to be hospitalized but need to be at a skilled nursing facility. So we are coming up with, again, innovative, different solutions. We are working on both short term, like what can we do tomorrow or next week, as well as longer term solutions like developing a nurse residency and fellowship program so that we can effectively hire nurses right out of school and get them trained up and confident to work at the bedside. Next slide. Some of the asks that we have of our Central Oregon healthcare ecosystem is, if you run a primary care system, that we would love for you to ensure that your patients are getting the care that they need, that you're really pulling them into visits, and then tracking if they are hospitalized, getting them into clinic, within 24, 48 hours post-hospitalization. So really trying to take care of patients and keep them healthy and out of our emergency department and out of the hospital, if possible. We would love for all of the clinics to expand urgent care if they can. Again, expanding same-day appointments, offering advanced imaging so that folks don't feel like they have to come through the emergency department for that type of service. And this whole issue around high utilizers, we're going to be doing some work with the different groups in town to share our information around high utilizers of the emergency departments across our region, and also frequent hospitalizations, so that we can together coordinate on how to keep folks at their healthiest state outside of the hospitals. And then I can't emphasize this enough, but getting everyone vaccinated who is eligible. If we can put a hard press on that and get our vaccination rate as a region up above where it currently is, that would be extraordinarily meaningful. And then the last slide is just, again, this reminder that we have for all of our caregivers and all of our patients and families, is to wear your mask, get vaccinated, go see your physician. They probably miss you. Practice good self-care. This is stressful times. I think we're trying to encourage people to develop healthy coping mechanisms that contribute to health and well-being. Don't delay care if you need care, but just go to the right spot. So if urgent care is appropriate, we encourage that rather than going to the emergency department. And I feel like at this stage in the game, we have a responsibility to talk to our neighbor, to talk to our family and friends, and really encourage them to make the best choices, again, primarily around vaccination. So Rick, I see that Dr. Absalon and Joan joined us, and I know that this information probably set off a lot of questions and discussion points. So I turn it over to you to maybe facilitate a dialogue.
Sure, and I just wanted to start with whether Dr. Absalon or Joan want to jump in and say anything on top of what Iman just said.
Rick, thanks for the invitation, and Iman did a great job of outlining it. Thank you guys for the time and collaborating in every way possible to help. This is really, it's really a pivotal time for us. You know, this is a confluence of factors, and like I said, I think Iman outlined them, but we're anticipating more patients. And as we've seen these surges throughout the pandemic, I think all of us will acknowledge and recognize that even though we've had ups and downs, we've continued to struggle in terms of getting back to what would be a normal state, and in particular, getting patients in for their elective surgeries have been a real challenge throughout the time. So it really is a focus for us. And COVID, non-COVID patients, people that have delayed care, all those things coming together. So we're really just looking in every way, shape, or form to address this. The other thing that I will say is that we have been having quite a bit of conversations through the state. And we have just gotten word late last evening that we are going to get some support for staffing from the National Guard. And so we're preparing for that in a way to kind of help out. Unfortunately, it's not likely to be very many or any nurses, and because they are very understaffed with nurses as well, and they're working in their day jobs. But we've been looking to every venue possible to try to find assistance. And so there's a lot of things in motion right now, and just appreciate the time to talk about this, answer questions and dialogue. And I'll turn it over to Joan if Joan has any words to point out.
Yeah, good afternoon, everyone. It's nice to join you. Some of my thinking over the last few weeks has been how much our community is tied together, how employment and economy, healthcare, everything from the ambulatory care to the post-acute is so interdependent and woven upon each other that at times it's felt like it's difficult to find solutions for some of these hard problems because we're constrained by something else if we should do something. So I'd love to be able to answer questions about how we're partnering in the post-acute space in particular to try and offload the patients that could be discharged to the community but don't have a place to go, and some of the novel ways that we've been approaching it to be respectful to these patients and to their families, and yet also to make room for those who really need the care.
So I'd like to hear from other folks and just what is your experience about how this all is impacting, as Iman said, not just the fifth surge and the third big one, but the wear and tear on the staff and staffing problems that I think we're all experiencing, and also whatever glimmers of hope you might have. And I just throw this out to anybody to jump in.
Rick, it's
Yes.
Commissioner Adair, and I was just wondering, after seeing the Mayo Clinic report that came out, the fact that the Moderna vaccine is much more successful, almost double than the Pfizer, I'm wondering, when are vulnerable people going to be able to have a booster if they were vaccinated and completely in, let's say, January? Have we heard anything when they will be able to get a booster shot? And then according to our county numbers a week ago, we were at like 72.2%. I'm just wondering, I know it's not high enough because now you're saying 84% for herd immunity, 85% for that herd immunity. So those are a couple of my questions.
I'm happy to take that. If anybody else wants to chime in, certainly welcome. We do anticipate that potentially there will be a recommendation for booster shots. We don't have that yet, and the FDA is working on that, and the CDC. And I think that what we would anticipate is that it's likely that there will be booster shots recommended, in particular for people in older age groups, as well as people that have an immunocompromised state. Uncertain whether that's going to include healthcare workers or others, but we'll certainly be watching to see what the recommendations are around that. And there's lots of activity, thought, and exploration into that topic right now. So we'll just need to keep close to it very much. As far as the vaccination rates are concerned, the one thing that I would just point out is that Yvonne shared the 84-85% for the Delta variant, and that has to do with the fact that it's more transmissible, and so it's going to require a higher amount for herd immunity. But in terms of reciting vaccination rates for our counties and our communities, I think we just need to keep in mind that those are vaccination rates of eligible people, and so currently, kids under 12 are not eligible, and that's a significant population. So we think that the vaccination rate is probably closer to 50% overall for the population. So we've got a long ways to go. And, I just point that out because we recognize that vaccines, as well as masking and all the other measures that we put in place, are so critical to getting us out of this situation. This is a time when we've really got to take a full-scale effort to get that up. And I will just share with you guys, it is so heartbreaking for our staff. This far into the pandemic, taking care of people, which they do and they are committed to doing every day. But at this point in time, the degree or the severity of illness is largely preventable by vaccinations. And it is heartbreaking to our staff to be taking care of people in circumstances where they and we all believe and know that the degree of their illness is largely preventable. So those are just few comments that I have, and I'll look to others if they have additional comments.
Rick, could I share a personal experience in the last month that I've had with the St. Charles system through my husband's experience?
Sure. So Linda and then Justin.
About 5-6 weeks ago, my husband visited the St. Charles Urgent Care. It's the second time in 6 months that a member of my family has done that, and in both cases needed a CT scan, so we were referred to the emergency room. So when you ask about ways that we can keep people out of the emergency room unnecessarily, you might want to look at investing in some equipment there so that people don't come and have 2 visits, one of which insurance won't pay for. Came to the emergency room, and we had to come back twice because the first time was a non-surgical diagnosis, and 2 days later, my husband was admitted for emergency surgery. And the care that we received was amazing. The nurses, the admitting staff in the emergency room, there were homeless people there, there were people hurting. It was crowded, and the staff was impeccable in the way that they treated people with care and respect, regardless of their station in life. And there was backups, of course. The surgical care we received was excellent. The nursing care we received was excellent. What we were told was that if this had happened a week earlier for my husband, we would have been shipped to Boise for care because the hospital is stretched to a capacity. He went home, unfortunately was readmitted 3 days later for another week. The only other issue we had with the whole continuum of care, besides the fact that we got excellent care throughout, was the interface between the community provider when we were referred and seen at the emergency room the first time, referred back to the surgeon within 2 to 3 days and received, well, they won't be here. We can't get you in to see the surgeon for 2 weeks. And those sorts of glitches, I think the system can look at. And the other piece that was unfortunate that I think is a result of the crowding and the demand throughout the hospital is that when my husband was unexpectedly readmitted, the surgical floor was full. So the only room they had in the house was in the intermediate care unit. And he didn't even have an IV. He was there for pain management and to try to get his intestines to calm down. And so a highly skilled nursing staff, inappropriate patient on that floor. And I say that as a healthcare provider myself. So the care was excellent. The nurses and everyone, traveling nurses, CNAs, physicians, communication among the team was impeccable in the hospital itself. But there are some ways I think that the care community outside the hospital doors could do a better job of coordinating if the goal is to keep people out of the emergency room.
Justin.
Sure. So I would just say I don't envy the position you'll have. I know it's extremely difficult. I do think, though, the conversation, at least from my group's perspective, has been going on since October of last year, when we started canceling surgeries in the community pretty consistently all the way through. So we're looking at over a year of canceled surgeries. And I think, to a degree, I think what's frustrating for me in the conversation is that we're not really putting any definitive performance numbers to things. So how many COVID patients can you have before you'll reopen surgeries? How many COVID patients can you have before you'll be able to operate effectively with all of the items you walk through? And I find it frustrating, or maybe a little lack of seriousness, when the community does offer you resources like my group has multiple times for discharge planning. We've offered you free FT, and so has the IPA. So I think, if you get into situations where you come here to say, how can the community help you? And the community has offered for 10 months to help you, and you won't take the help. Maybe part of the problem, to a degree, is that the only solutions that will work are the ones you're coming up with. In a situation where you have bed capacity issues, certainly staffing is everyone should focus on that. But how to effectively get patients out of those beds quicker is probably also a really effective strategy. And it seems like a large part of the presentation you just gave is, this is happening everywhere, so we better just be prepared for it to happen. excellent leadership, though, is about trying to find out ways to, when you're in a pandemic or a crisis, come up with better outcomes than everyone else is getting around the country. And so while I've heard this, I've been part of setting through listening to the same story now for months and months and months. It doesn't seem that there's much of an effective long-term strategy that's going to fix this. Like, for instance, I just heard, from you again, that long-term care beds in the community is a problem. Now, you could build those if you'd like to, or you could propose to the Health Council that they take 20% of the inpatient capitated rate and give it to long-term care facilities so they have an incentive to build more beds. All solutions that just don't get presented. There are a lot of, here's the problem, but no real quick solution that you're coming up with, except for eventually, hopefully enough people are trained or enough travelers will come. Housing is always another situation. And there are a lot of groups around the country that are coming up with innovative ways to purchase housing. They purchase it themselves and then become landlords. Maybe that's not the business you're in or what you want to do. But again, if everything is the way it is with no solution, and then when people come with their ideas and offer you help, you don't take it, I think that's part of the problem. And you have to also understand, if you don't do surgeries, a lot of that ER utilization, I know 1,000 people needing hip or knee surgeries, isn't critical. You don't have to do that right away. But the 6 months those people wait for surgeries while they're canceled multiple times, when they have pain, they're going to come to your ER. So to a great degree, you're inducing your own demand with some of the problems. And maybe that's just an outcome and that's just what it has to be. But ultimately, the conversation's been going on since October. This isn't really as much just a Delta variant issue. And if it is, it would be terrific for you guys to just define with new numbers. Come here every month with numbers and say, hey, if we get below 20 COVID patients in the hospital, we'll have more than enough capacity to begin surgeries again. If it isn't COVID numbers and it's staffing and purely just staffing, then how many more people do you need until you can adequately, because it sounds like you have about 300 beds and you have, by the slide, 32. So 10% of your capacity is tied up with COVID patients. So I hope, I don't know that everything I know that's a lot to have thrown out all at once, maybe because the IPA, myself, and multiple groups have been involved in this now for 10 months. But I'd really encourage that maybe part of the problem is that the only solutions that are acceptable to you guys are the ones you come up with. And perhaps if you're coming and asking for help, you have to be willing to take it when people are willing to give it to you.
So before we get a tit and tat, I want to broaden this discussion, and we have some people who have hands up, and so Divya's next, and then Brad Porterfield.
Yeah, again, I think has been a concern. We have been trying to figure out ways to collaborate, and it has been a little frustrating. I guess I just want to kind of understand, thinking about, I think that's the point of the delayed processes or delayed care, and that's impacting hospitalization, completely valid. And at the same time, it's like we're caught in this vicious cycle when care is being delayed because of no access point of, say, surgical repair. So the ones that have to be done in the hospital. I think the community has stepped up with ambulatory surgical centers working around the clock, trying to expand as much as possible. Surgeries that traditionally were being done inpatient are now, as much as possible, if they can be done outpatient, are being done outpatient. So there's a lot of that happening. I think, even, for example, social workers from COPA, that traditionally had been in the hospital, were asked to now leave the hospital. So the workforce that has been there in the past has been taken out of the hospital. The offers that we're trying to make, and that wasn't supposed to, those aren't supposed to be the end point. There's kind of a starting point of how can we collaborate? How can we pitch in? How can we lean in so that we can then continue to look downstream and work on? I think it's been a really frustrating process because it does feel that in good faith, these conversations aren't going anywhere. And while we're hearing the challenges, and it's not just a hospital challenge, this is a community challenge. I mean, our providers are struggling, our patients first and foremost are struggling. So we're just feeling a little kind of with our backs against the wall because we don't know how to deliver help, because it doesn't feel like it's being received in a collaborative manner.
And so purposely want to go to Brad and then move from there. Brad.
Thanks, Rick. First of all, I just want to say that I love the honesty. I think it's good for everybody. It definitely sounds like work needs to be done offline to make some progress on what has been raised. But the one thing that's swirling around my mind is when we look at, especially making like public policy decisions and any kind of mandated behaviors, is the health field incorporating all the natural immunity that exists of folks who've been infected into, looking at that herd immunity question? I know there's probably overlap between folks who've been infected and gotten vaccinated, but is there any way to see that data and include all that natural immunity?
Jeff, are you able to speak to that? Because I know that Dr. Marie, our infection prevention medical director and hospital epidemiologist, she is, I think, working through crafting a messaging that if you've had COVID-19 in the past, you're at a certain risk of contracting it again. So I think that there's more evidence and science out there that having had COVID-19 does not get you to the level of, I think, if you were vaccinated. But Jeff, do you know, or any of the providers on the call, do you have more information on that just yet?
No, I think you're correct about that. And people that have had COVID still need to get vaccinated. And so that's an important tenet. The reality is we're either going to get to herd immunity by vaccinating people, or eventually by more and more and more people getting sick. And that is, we are looking at that, by the way, and you can see where the number of people getting sick will increase over time, but there will be a lot of destruction between where we are now and when we ultimately get to a herd immunity level, incorporating those that are vaccinated and those that have been sick. But Iman is also right. As this virus continues to change and mutate, it's really important to still get vaccinated, even if you've had COVID, perhaps from a previous strain. But I also would like to just respond to some of the statements also that have been made up to this point in time. And our challenges right now, it's absolutely true. They are not just COVID. And as was outlined, there's delayed care. We hear from our emergency room doctors every day. They're seeing people that show up that just moved to town and don't have a doctor. Okay, and so this is COVID, it's delay in care, it's growth in our community, it's aging of our community, it's increased cost of living and loss of workforce. So there's so many things at play here. So I don't think anybody's saying that this is all COVID, but it is very fair to say that as we're watching what's happening in Southern Oregon, and we sure hope that we don't follow suit. But I have to say, looking at our county numbers, look like we will be following suit in these days and weeks to come. COVID is a tip over the top thing, and so I don't want anyone to think that that's the only problem, but it is certainly compounded significantly. As far as the solutions and partnerships, it's really important for us to understand what the problem is and what are potential solutions that will move the dial. And I think, as you've heard today, and this is where we've been putting a lot of attention, this is a workforce problem for our clinical workers, nurses, LPNs, et cetera. And some of the work that we're doing, I know that Joan can speak to in partnership with our post-acute care facilities to help get workers to them so that they can open up beds. There are beds available, but they are unstaffed beds. And that's true for our community partners. And just as we have the same staffing challenges. So I think we're really trying to focus our efforts on where we believe the root cause of the problems are. And, if people in the community have RNs and LPNs that can help out, that's where the need is. If they can help out in long-term care facilities or assisted living facilities, or people that are appropriately trained to do that kind of work, this is a huge concern. When we've got 42 people in our hospital that don't need to be there, it is absolutely a huge concern. But I do want to just say, we generate ideas. We appreciate others generating ideas. We're willing to look at and partner on any ideas, but we need to put our effort where the root of the problem is. And so, that's where our efforts have been. And Joan, I don't know if you want to add on to anything that I just said about nursing, LPNs, et cetera, in the community, but that's the challenge right now.
Yeah, so I'm a relatively newcomer to Oregon. I hail from Washington State, and we have many of the same problems that Oregon has. I think one of the problems of when we talk about root causes is there really is a shortage of CNAs across the whole US, right? These are positions that are entry level, and we're competing against other industries to develop these people. When we interview all of the CNAs who enter our programs, we try to run between 10 to 20 individuals through a program and develop their skills so they can sit for a CNA exam. About half of them say they want to stay in healthcare. They eventually want to become a registered nurse or a surgical tech or a doctor. And so one of the things that that I've recognized is that we don't have a good developed pipeline from our community colleges through our baccalaureate programs that makes it really transparent for people entering the field how they can then further their education, their experience in nursing home and hospitals, so that they can attain a level of education. They also need financial assistance because it's not possible to work full-time and go to school. So some of the things that we've been working at St. Charles is to work closely with COCC and with OHSU, as well as OSU Cascades, to look at that pathway and pipeline, as well as the articulations in education. More recently, because of our problem with not being able to discharge patients to assisted living and skilled nursing facilities, we were approached by Ben Transitional Care and asked if we could potentially fast track our CNA training program. And so what I mean by that is we have CNA trainees who have gone through class and are about ready to sit for their boards. In the time that they are waiting to take their boards and while they get their results back, we're now sending them as CNA trainees to Ben Transitional Care because they are severely understaffed. From 45 beds, they can open up to 60 beds. And in exchange, we're able to discharge more of our patients who need skilled nursing to Ben Transitional Care. So we're in talks with the COCC now about making this a formal kind of a program where our CNA trainees start at Ben Transitional Care or at Regency. And when they have enough experience, then they matriculate into the hospital and begin to work in the hospital. And then I do have a plan for those that want to go back to, let's say, COCC for their ADN, that we would help them and give assistance while they work to achieve that next level of education. So those are some of the kind of creative solutions that I know many areas of the country have instituted, but I haven't seen yet in Central Oregon. And that's something that I hope that we'll do more partnering on in the community with individuals like you.
So a couple of things. One is whoever's on the phone from Prineville, the 447-667-72, can you put yourself on mute? That would be helpful. Two is I do want to emphasize that we cannot underestimate how stressed all our systems are due to 18 months of this problem. And I know we like to get to management. We're going to do this, and this, but I see every day the impacts in all levels. State workers are all like working from home and their systems are deteriorating on a daily basis. And, you just see this in all sorts of areas and we're all stressed. So the third thing is I'm hearing the community say very directly to the hospital staff that there needs to be a more concerted and planful effort at collaboration than has happened in the past with these key community partners. And that needs to not be just a happenstance thing, but a very mindful, thoughtful, action-oriented plan, and that the key community partners are willing to come together to help and feel frustrated about that. And I say that because I'm on the side a bit here in behavioral health, but I'm just hearing that from the meeting. And so I see that Kim has his hand raised, and then wondering if there is some way that we can move forward with, as Iman said, desperation sometimes creates innovation. And so this may be a tipping point where folks can come together. I don't know. Kim. Okay, Kim, you're off mute, but you ain't talking, which is very rare for you. Okay, well, we're missing his profound insight right at this point. Hopefully he will circle back or put it in the message. And good, I see Judge Crawford is dialed in. So, so let me put that, so that's sort of the messaging I'm hearing.
Rick, can I'm raising my hand, but you're not seeing it. Can I just?
Please.
One thing, like I think Jeff was just mentioning, that there is a lot of context here that's creating the situation that we're in, but we do have a surge coming, and we do have health systems likely ahead of us with their surge. I heard there is a health system on the coast that's putting a tent up to take care of patients in a tent. That is true in other states as well. And I think in the near term, one of the opportunities we have with this increased volume going into the ER is being even more creative around primary care and access into primary care and some management of some of those folks to pull that volume out of the hospital. And I think that's an area, in addition to some of the other efforts that have been talked about, that I think as community partners that we can come together on. And so I just wanted to, just in the near term, I am feeling a little urgency around that opportunity to increase volume, in addition to the SNF efforts to bring in more staffing to the SNFs. And there's also, a look at doing some SNF level care in homes. And then the other area that I'm hearing is around transportation, that there's some barriers with transportation as a reason folks are in the hospital longer. And is there some effort that could be done quickly to help with transportation to offload some of those 40 patients that wouldn't be a heavy lift that would help us out even in the next few weeks? That's just my lens too. I do think there's a longer term pathway and solutions and planning over time, but then there's this sort of near term reality that we're in, that we can work together to try and offload to create more capacity in the system.
And with Tammy here, she has the pulse on transportation. So we can pull some things together.
If you want me to respond, as you all are likely aware, about a year ago, year and a half, last year feels like it was maybe 10 years, but we no longer are the brokerage for the CCO, but we do provide transportation services for all other transit services in the region. I was unaware that that is an issue, but I mean, our team, we've been running shuttles to and from the cooling shelters. We've been running emergency evacuation to a wildfire in Redmond. I mean, our team is nimble and can be, creative, if you will. So I'm happy to have a conversation. As with everyone else, if you have a CDL license right now, we'd love to have you come and drive for us. But staffing capacity is a challenge. But our goal in the region is to meet the need. So if there's something that we can be doing, especially if we can identify, a time frame, the answer is absolutely.
Thank you, Tammy. I think some of the issues that Megan is referring to is just the timeliness of getting a patient transported, maybe from the Bend Hospital to Prineville, to get into a swing bed, which is a lower level of care bed. And, how do you do that and not have to wait 4 hours or 6 hours? Because again, that next patient is waiting in the emergency department for a bed. So we're trying to become more nimble and not kind of tolerate those long delays. That just again can contribute to the gumming up of the overall system. So we're getting creative around that, and I think developing different partnerships. But companies, just like what you said, they may have a fourth rig to offer, but they don't have the staff to drive it. So this whole workforce shortage issue, I think, is across the board in all industries, including transportation.
So Iman, and you can slap me here because I'm really wading into areas that are way over my pay grade. So I'm just trying to be a group therapist here. And so I'm hearing pretty direct offers from the community about concrete help. I do know that these are very complex systems and very complex, there's all sorts of problems with getting from a well-meaning offer to actual doing something on the ground. Is there a quick and nimble way, because we don't have a month to plan, we want to do something in the next week or two at most, I would think. So is there a way to actualize that in the near future, or would it be helpful if COHC is a neutral convener of that discussion, or do you want to take the lead directly as part of the executive team at the hospital? What are your thoughts?
Rick, is there any way to request that you guys step in and maybe be the convener? I think that'd be great.
Well, I just did that, so I'm on. So
I mean, I think again, we welcome all solutions as far as exploring them. What we uptake has to make sense. So just because something is offered, it doesn't necessarily address the root cause of the problem. What I understand is that we're fully staffed in certain areas like case management, Justin, and so that the staffing issue isn't the contributing factor to getting patients flowing into placements outside of the hospital. The challenge is actually the staffing at memory care, adult living facilities, and SNFs across the region. So if anybody has any extra staff to redeploy in a similar fashion that St. Charles redeployed to Bend Transitional, I think that sounds like an awesome plan. We did make a request for 30 nurses through the National Guard to help staff patient beds. If anybody on this call has access to RN resources that they would be willing to redeploy to the hospital, I know we would take those resources. So again, and I know you framed it this way, Rick, the resource offer has to match the problem. Otherwise, we're just contributing to other problems. So the resource mismatch, I get it that some people might perceive as being helpful, actually isn't going to help with patient flow. So we would welcome to discuss other issues, but I think if we could get people, especially unassigned people, into primary care that would be helpful. If you can ensure that anybody in your system is hospitalized, if you're getting them in within 24, 48 hours post-hospitalization, and if you're maximizing your urgent care and really communicating to the community that you are there for them for appropriate care that meets the urgent care need. And then I would love for every clinic, every county entity, every behavioral health therapist, Rick, to encourage their clientele, their patient population, their staff's family to get vaccinated. And then the last thing is to wash your hands.
And Rick, I'd love to just ask that maybe you do convey that meeting. I think that'd be great, because I think we could bring specific patient examples of people who are waiting for multiple days for a social work evaluation from the hospital, and we can just use actual examples and get out of the back and forth of like, it sounds like the only solution that is acceptable is what is St. Charles solution, and maybe part of the problem that you could help with, or Pacific Source could, in setting on these meetings, is maybe the leadership determinations of what the problems are that maybe that's how we got here in the first place. Maybe we're not, the question is, what problem are we trying to solve? Maybe the folks who are answering that question aren't all that good at picking out what we're trying to solve, because I very much believe if we were to look at the average length of stay on patients, there are going to be multiple people who aren't just waiting on a transitional care a bed. And I especially think that will be true if you were to look at the weekends and the ability for discharges on the weekends. So I just think if we had some third-party convener who could set in, and we could look at actual examples, maybe everyone on the call would come away saying, yep, that's the problem we're trying to solve, instead of just blanketly accepting that the only issue is transitional care beds, because I think there are a lot of patient examples that that's not true.
And Divya, I'm circling back to you. Do you have any thoughts? I'm just sort of following an order that we happen to start.
No, I agree. I think a third party present, and for us to really look at from all sides the root causes and really what is it that we're trying to achieve, and are there different ways we can get at those, and to have an open discussion. I know this has been an honest, really hard conversation. I actually also congratulate us for the first time having those conversations, and not just always patting ourselves on the back. And because I think the intent many years ago was to have a group like this where we could bring some of those difficult conversations.
So I think clearly what everyone is saying is that the root causes are both in the community and in the hospital. And many of the causes are shared, staffing shortages being one of them. And if the staffing shortages on the long-term care facilities are anything like the staffing shortages are in mental health residential, then we're all screwed, because they're massive.
My only other comment I was going to make is I think this is really critical for us to have this as a community and all this. I don't think this problem, even outside of COVID, is going to get any better. Our community is rapidly growing. And so there are challenges that are coming even if and when, God, we get out of this pandemic.
That's
so,
what I would.
Go ahead.
It's Commissioner Darren. That's actually what I want to say. Thank you for saying that. In July of 2019, when I had my ambulance meeting regarding Deschutes County, all the beds were full in Deschutes County. They were full in the entire state and in Idaho at that moment in time, with the exception of Legacy and Manual. And I was like, oh my God, why is this happening? What have we done since? And this was pre-COVID. And then doing a historical analysis, I looked at the hospital I was born in 99 years ago, St. Anthony's in Pendleton, had they had 75 beds. Today, the brand new huge hospital has a bloody 24 beds. 100 years later, and there are no beds. So, what is it? They're having a major COVID issue there, and there are really no beds at St. Anthony's to speak of for that community. The population clearly has increased. And, that's why I worry about St. Charles. Our population has increased so much the last couple of years. Are we truly adding more beds? Are we really adding more beds? So anyway, thank you for pointing that out, Dr. Sharma.
And Rick, it might help you to move this along and in a positive direction is I know that St. Charles would be happy to be a part of a convening after we finish the initial stages of our master facility planning for our system, because I think that it's so important for the community to be aware of the issues that Commissioner Adair bring up as far as how are we building for the future? How are we able to care for our community together in partnerships with others? And what are the projections of growth? And then what are the projections of growth as it relates to hospital beds? What does it look like with a well-managed population? And I know that Pacific Source and Summit and Mosaic and High Lakes, we all have a piece of that. Like if we well manage our community and people get care in the right place, what does the need for our hospital beds look like? And again, to the point of can we then also build in like a 20% buffer so that we always have a bed available, so that we don't cancel elective surgeries, that we do have good patient flow. I would love to do that. And I would love to have like a community convening around that and the sharing and have, the community's input and fingerprints on that. So I think that we can do that. I think that we need to make our way through this current kind of situation, knowing that it is probably not going to resolve in any meaningful way for a while. So we just have to kind of, do that convening regardless of crisis. That's what I've realized. So
Iman, I think where I'm going with this, and again, it's just an idea. And from a guy who's like wading in way above his pay grade. But so it seems to me there's two time periods we're talking about. We're talking about an immediate crisis. Can you get through this wave and the potential of the next wave without putting tents up in the parking lot? And then a longer term thing that manages the growth of the region. So two separate processes. So they can intersect because sometimes figuring out how to manage the crisis gives you lessons for going long term, maybe possibly creating connections that have not been created before. So I'm proposing to the healthcare leaders, or asking rather, is that a reasonable process? Is, hey, let's do something really quick, and can this system be nimble enough to give the hospital, creating a system between the hospital and community, some emergency supports to get through this? And that can potentially create some learnings for us as we reflect on the longer term problem? Or is that really, it's too complex to create such a nimble process?
Hey, Rick, can I chime in for a second? I'll go after you, Linda.
Please.
No, it's okay. Go ahead.
Go ahead, Jeff.
Okay. Yeah, thanks for the dialogue, everybody. I mean, the crisis that we have right now, I think it's absolutely true that some of the solutions for the crisis right now are the long-term solutions. And building more hospital beds may or may not be the right thing to do. But one thing that is certain is that we need to change how we care for people. And it's happening today. Patients are being sent home from the emergency room when otherwise, or prior to this point in time, they would have been admitted to the hospital. Patients are being discharged in some cases early in an effort to get them home. Those are people that don't need the support services that we're so backlogged in that we've been talking about. And so I would say the immediate action is, and I think this is aligned with everything that the council is interested in, as well as the practices in our community, is we have got to have immediate follow-up and management of acute care conditions in the outpatient arena in a way that's different than it's ever been. And so this means a different and more nimble role for primary care across the continuum. It means a different and more nimble role for home health. It means a different, potentially different role for things that we're exploring, such as hospitals at home, SNFs at home, all of those things. So there's a lot of change, upon us right now. And I do think that those efforts and learnings are immediate fixes. Some of them take more time than others, but are going to serve us well in the short term as well as the long term. So I would encourage there to be strong and concerted dialogue and effort on how we can identify which parts of this change in care delivery we have already embraced and are doing well as a community, or where certain parts of our community are doing well that can share experiences with others. But I do think that's, from my perspective, that's where we need to go right away. Because we're not going to, as we've acknowledged, it's not a physical bed issue right now, and putting a tent in the parking lot still requires nurses and other staff to take care of people. So it's not a physical issue, but I think we need to put our effort on how do we provide safe, high quality, and in some cases much improved care in a very different way. So I'd like to see that be the focus and the way that we approach this collectively as a community, and again, learn from the parts of our community that are doing well or have ideas, and move forward accordingly.
So Jeff, what I'm trying to do is, you got in this virtual room, you got Divya there, who's medical leader for COIPA. You have Justin, who's can get Summit to do whatever he wants to get Summit to do. And they're offering help. What can we do concretely in the next week to help with this immediate surge? And what would you suggest that, is there a meeting that we can pull together, a little planning meeting, bang it out in a couple of hours, bring these resources together and coordinate, pull in Tammy for transportation if you need it, whatever. I mean, so I'm hearing offers. So I'm just, you're a clinical leader there. You know how all these pieces are coming together and what the need is. What is there an opportunity here?
Yeah, I think it is what I just shared, which is an opportunity to focus on immediate follow-up from the emergency departments and the hospital for early discharge for those that can address that. So we have, we're working that. And if people want to get in a room together and have a conversation, I would very much invite that. I do know that our ask is that every practice in town make the declaration that if asked by emergency department as well as hospital providers, that if in the cases where an immediate follow-up is necessary to facilitate best care where we are changing how we're delivering care, that happen right away. So I know that dialogue's happening, and perhaps it's a good idea to get everybody in the room to talk about that and solidify that. So that's my thought.
Sure, and I'm certainly offering up Donna to convene that. Justin?
Yeah, so I just want to tag on to that. If the issue is how can the independents and my group help get patients in post-discharge, no problem, but the discharge is part of it. Like how they come out from the hospital is just as important as how quickly we can get them in, work them in, and the notification system. So again, this is part of like maybe the problem is we're diagnosing the problem wrong. Healthcare is a system. It's not just one part of it. It can't just be the hospital saying, when we decide it's time to go, the community will pick up and take your patient no matter what state the discharge is in, no matter how poorly put together it is. What I'm saying, that's why I'm pushing so hard on this piece of who's doing it well? Well, there are great models around the country where Sound Physicians, Kaiser, a bunch of groups embed their own discharge planners in hospitals to make sure that those patients leave fully worked up and ready to get back into primary care. Now, if that's not part of the conversation, then it's not serious about trying to solve the problem.
So, yeah, Linda.
Just two things I want to say. I think that when I reflect on communities in crisis, the communities that survive are the ones that pull together right away and bring all the resources they can to the table to solve the problem, short term and then hopefully long term as well. So I support moving as quickly as possible, even though it may not be the total, it's a start on the journey together. And success at the small steps really keeps us tighter and builds strength for the future. The second thing I want to say is that having, as a retired health professional administrator myself, I know sometimes we think we know what the problem is. And I would strongly encourage us to have a patient voice in this, that whatever solutions are proposed, we have the people we serve, somebody representing them at the table.
So
great point.
What I'm hearing enough consensus about is have Donna pull together in the very near future a meeting, one-time meeting, see if you can bang it out. If it's useful, if it's not, move on. I would be thinking workflows across systems, because that's what I'm hearing is missing. A simple declaration, you guys do it, won't work. We all know that. And so I'm banging out workflows that everyone's agreeing to, and then we can monitor whether that happens and pull in whatever support needs to happen with that. So is that an acceptable solution to all parties? I mean, an acceptable next step to all parties? And I sort of look to you, Iman and Jeff. Does that make sense?
I'll definitely participate and I'll bring some people.
Yeah, for sure. I guess I would just want us to go in open-minded. You know, Justin, you're raising an issue which we have had group dialogue on. So I just want the full COHC board to know that we have met several times on this very issue that you're raising. We've shared with you our position and our perspective. And I guess we would also ask for you to respect that and to understand our decision-making around that. But if you feel like there's more to discuss, so I don't want to get in a room and think that we're going to change our position on your request to have Summit BMC staff working in the walls of our hospital. So I just want to be clear on that so that we're not setting up different kind of expectations. Understood. But if we want to get together and talk about what are some of the challenges and, you know, what are some other solutions, we're happy to do that as always.
No, I totally understand what you're saying. It's the answer there is whatever potential for reevaluating that. And it's not just Summits, it's the IPA's request. But that's a no for right now. And can the rest of the community that might have significant concerns about how to do the discharge better, can we figure out how to step up and help you all take patients quickly as you discharge them? But the items that are important to us are off limits because you've already made a decision. So no problem, I'm fine with that. But, and we were more than willing to help you in the primary care space. Like doing something that's right by the community isn't contingent upon you doing what we want. But I'm just saying, if you're trying to fix the system, you got to fix the whole system. And maybe the problem solving mechanism is the problem.
Well,
and I would welcome the community partners around that, because I think that when it's just Summit BMC and St. Charles having the dialogue and with IPA there, I think we're missing the skilled nursing facilities, right. Memory care, the full system of care. Because again, I think we're only looking at it maybe from one part of the elephant, and I think that there's other components of it in order to get, I think, a better place. Yeah.
IPA is happy to be there. I fully support having people from SNF be there. You know, I can tell you firsthand, having received some of the discharge patients kind of coming out of the hospital, there are challenges. It's not as simple, and I can certainly share from a receiving end, from my patient side, what that looks like too. But yes, absolutely. You know, and we have, you know, community providers, and this is not just Summit. This really is, we're hearing it from many other community providers. And then I'm happy to have a conversation and encourage SNF to participate. Absolutely. I think they're a huge component of this.
What I would encourage, just to help with problem solving, is that at least for the meeting that we're setting up, that we keep that at a short-term time frame, next couple of months, right? Trying to fix a long-term systems problem during a crisis is not a solution, but sometimes the crisis can help inform how you solve the long-term solution. So
I'm going to put Linda on the spot. Linda, I would love for you also to participate. I think you've raised, you know, you've had a really good perspective, both from a kind of a community member, you represent CAC, and then being on this board and having some and health background. I think it would be great if you'd be willing to also participate.
Okay. And so Donna, you have you...
Rick from COPA, and I would really love to participate in that also. I know the pediatric population isn't necessarily the targeted population we're talking about with this issue, but because we are the mostly unvaccinated population within our clinic, we definitely are seeing kids coming out of NICU, pediatrics, and kids that are going to be coming to the ER because, like everyone else, we're struggling with access despite adding additional providers every day, you know, doing as much as we can to keep kids within our clinic. But I definitely have experienced that difficulty in trying to really develop that collaboration to enhance that discharge planning process so that our clinic as a care team in the primary care home knows who's there, knows what the plan is, because we are more than happy and very excited to really help elevate that work and get those kids back into our clinic, because we know that that's where we can take care of a lot of this and not burden our healthcare system.
Good, thank you. And Kim, you're trying to raise your hand again. Do you think you can talk again?
Yeah, I'm going to try. Hopefully you can hear me this time.
Yep.
All right, thank you. Hey, I just want to throw my support behind this. I appreciate the dialogue. I think this is very important, especially in the crisis that we're facing right now. You know, we've not seen this before. So getting together and coming up, I appreciate the long-term solutions that St. Charles has been working on for the long term. But together, the community needs to pull together now, and the independents are very, very involved in this and want to be more involved with it for the solutions for the whole community. So I just cast my support from COIPA behind getting together as soon as possible and coming to solutions that will come to fruition. Not just hearing each other out, but actually putting sound decisions to work for us so that we can pull ourselves out of this and then put the long-term solutions in place.
Okay, and so then, and Megan isn't here, but I'm going to throw her into that meeting also. The last meeting I heard from Andrea Kettleholt is that the Medicaid population has a vaccination rate that looks like Alabama. And so really a hotspot population within our community. So since FQHC is a huge provider of that care, would like them involved. So Donna, is that sufficient marching orders?
Yep, I got it, Rick. Thank you.
Okay, and so we can go next. I'm going to close this discussion, very fruitful. I salute everyone for having this discussion. And the great thing about a Zoom meeting is none of you are throwing food at each other. So that's a good thing. And really appreciate everyone's willingness to have that discussion. So
Rick, we're going to swap Leslie with
Yep.
ops. Thank you.
Right, and so I think Emily Solomon had to leave, and so we're on Janice. Are you with
Yeah, I
us?
think Emily is still here with us for a few more
great,
minutes. So.
okay.
We're both still here. And this is Andrea. I think I'm going to start this presentation, and so I'm going to share my.
Can I just say a couple words, Andrea?
Absolutely.
that was quite a conversation. We didn't anticipate sort of being in the audience. So I just want to appreciate this group's ability to talk honestly with each other. I don't see a lot of groups that do that. We're going to be talking with you about QUIMS, and I just want to acknowledge that we're talking about that in an environment where people are enormously fatigued and doing their best. So Andrea and Emily and I were texting with each other, communicating with each other yesterday, talking with each other by text, just as this meeting was continuing on, about really letting you decide how you want to make use of this information today. It's information that you deserve to have, you should have, and may or may not have the energy to think about or problem solve about today, but we wanted to make you aware and take it from there. Thanks,
Thank you,
Andrea.
Janice. Of course. Which slides are, I've got three screens going on.
Andrea, we can see the notes version or the presenter version.
Thank you. I might just, let's see here. I might just not put it in present mode. How about that? And I'll just make this bigger. All right, so yes, thank you, Janice. And I think one hard conversation is kind of going to lead into another hard conversation. And I think to what Janice said, all of us, and I can say, you know, really for all of the ops members, the work that is done in Central Oregon, and these are specific for the Medicaid quality incentive measures, is not lost in this conversation. We know the work, we know the fatigue, and we understand that, but we also feel kind of that duty and ownership to share this with all of you. So again, this is Medicaid quality incentive measures, wanting to share with you kind of the pace and the trajectory that Central Oregon CCO is on track to meet. So I know there's a number of people in the room who don't live and breathe these quality metrics. Just to orient you a little bit, each year the Oregon Health Authority selects a set of quality metrics for our Medicaid members. In 2021, there are 14 metrics. 3 of them are must pass. So we kind of take them out and set them to the side, leaving us 11, and we must meet 9 of the 11 metrics to earn our 100% payout. And what that means when we say 100%, it's about 15 million to the CCO. Then of course goes in many directions, but flows back into the community through our providers and a number of entities. Because of and please interrupt me if there's any questions, but because of all the things you were all talking about in that last conversation, we're seeing that reflected in these quality metrics also. When we look at data through the end of June, through Q2, right now the CCO is on track to earn about a 50% payout, leaving about 7.5 million on the table. This is, and I'll get to this in a couple of slides, but this would be a performance Central Oregon's never seen before. Central Oregon usually always receives 100% payout. One of the past 8 years, we did not get that, but otherwise we've always been at 100%. So this is an anomaly and a first time we've been in this position. I think, you know, kind of a testament to the impact that I think the pandemic and just, you know, our community's response. You can see 3 pretty big pediatric measures in the red. You know, these aren't COVID vaccine, but these are our standard, been around for many years, immunizations that kids, especially these 0 to 2-year-olds that fall into this bucket, are not on track to meet. The adolescents are kind of those 11 to 13-year-olds, so a little bit different population, but still we're talking about communicable diseases that normally Central Oregon does very well on. So wanted to bring this to you. We're going to dive in. When we take a look at these measures, Central Oregon is very unique in the fact that we know through analytics that without our big organizations meeting these metrics, the entire CCO, all the small entities, all the small providers and provider organizations can't make up that difference. When we look at that based on the assigned lives to these organizations, that leaves Mosaic and St. Charles as the two largest groups. Again, we know through analytics, if neither St. Charles nor Mosaic, which we also know these two organizations role in the pandemic and the response to COVID, but without either of those organizations meeting these metrics, everybody else combined cannot meet the metrics and overcome, what those two big organizations carry. So it is pretty imperative that at least one of the two big organizations meet the metrics. When we take a look a little bit more and trying to illustrate this, these are some of our dashboards that we review, we share externally kind of wide and far across our, our health council, all of our provider partners, the IPA, everybody gets these dashboards. But it is really, it illustrates very nicely when we take a look at, like, say, this well-child visit metric. This is focusing on 3 to 6-year-olds. And again, just as a reminder, we're only talking Medicaid members. There's about 5,900 total in the CCO. And when we break them down by where these kids are assigned to for care, this is kind of what it looks like.
Andrea, I think Justin had a question.
Sure, Justin.
Yeah, I'm sorry to interrupt you.
That's okay.
I got a report on this week from my quality director, and we did a call with Pacific Source right before, we just did it, I think, a couple hours ago to lay out our plan. During the conversation, it sounded like there was a shot that we could make it. Is the situation, or maybe she just meant our group versus the overall, but like, is the situation in a point where the group cannot make it? Have we missed more than half the opportunity, or there's still 5 months left, right?
Absolutely, Justin. And I think you bring up a great point. We can turn this ship around. Are we going to meet 100%? I don't know if we can make up that recovery on some of these metrics, but we can absolutely turn around adolescent immunizations. I mean, we're 3 percentage points off of the quarterly target. I have no doubt that we can make those up, and there are enough denominators. 3 to 6-year-olds, that's just an appointment by December 31st. There's no other deadline.
I'm sorry, it's my misunderstanding. We talked to Teresa. She let us know she was real confident in where we were at with our plan. Yeah. I just misunderstood that to mean the whole group. My bad. Sorry.
Oh, no worries. But I think you bring up a good point that we can turn the ship around on some of these metrics and get a better performance.
Okay, continue with your presentation, Andrea.
So then kind of looking at some of this is just kind of illustrating, where these kids are at in some of these metrics. This is those childhood IMS. This is a new metric around alcohol and other drug abuse. So I think we can do it, to Justin's point. I think we can turn these measures around. It's just, what is our strategy? What is our action plan? And what is our mitigation if, we miss a target? This is kind of that slide that I wanted to really take a look at. It does a really nice job. So here's our years over across the top. quality pool funds, the percent we've earned, as you can see, we've always hit 100%. We had one year that we only met a 70% payout. But then when we take a look at our total funds earned, so when CCOs don't earn 100%, the money goes into an additional bucket called the challenge pool. And for every metric you meet that's part of this pool, you get extra dollars. Pacific Source, the Central Oregon CCO has done a good job. I mean, in 2019, we got 145%. So we know the work, the workflows, the dedication that these metrics have in the community. Right now, though, like I've said, we are in this anomaly that we're not on that trajectory. You know, right now we're about to leave 5 or 50% on the table. But again, to Justin's point, we can turn this around. The other thing that we've done internally is really taken a look at how does Central Oregon compare to our other 4 CCOs, and it's nice to have those the other 3 CCOs. It's really nice to have that just to be able to compare. Are we on track? Are we way off base? You can see on those 2 immunization metrics, Central Oregon, we are behind. I mean, is this across the state that, everybody's behind? I think this does a good job of demonstrating that there are CCOs meeting these metrics. Wild child visits, I can tell you everybody, at least our 4 CCOs, we are all struggling. And I can't get my fingers on that root cause. Is it parents concerned about COVID? Is it parents kind of feeling like, well, we didn't do it last year. My kid's healthy, we're fine, we'll continue. We have huge strategies going on. Pacific Source, we are deploying about 15,000 postcards. A lot of our organizations who are co-branding those postcards are also doing phone calls. We've seen this effort yield about a 25% lift in performance. We know it's possible. Initiation engagement, this bottom metric or kind of this middle metric, it's a hard one. It's all about clinical workflows. But again, we're close enough that I think we can get this flipped around. We just have to really dig in and take a look at those clinical workflows. How are we utilizing our integrated behavioral health providers? And again, this diabetes poor control metric, we know it's a hard one. We know it improves towards the end of the year, but I think kind of like the conversation earlier and a little bit different, but where is that care management, especially for these members? Have they come in? Are they getting their diabetes, their A1C testing done? If they're getting it done, where are they getting it done? This population, we know, has really suffered through this pandemic. How do we get them to engage and get these numbers under control? And then when we look at COVID vaccines, I think, Rick, you were saying how our numbers look like Alabama. I mean, I can't say there, but for when we look again at the 4 CCOs, OHA created a metric tracking COVID vaccines amongst our Medicaid members. Right now, Central Oregon, and granted this lumps together all 3 of the counties, but for 16 plus, based on alert data only, our CCO members are sitting at about a 38.1%. Our goal is to get them to 47.4. This is what the metric says. Of course, this is not herd immunity or any of those other bigger components. This is just what OHA has created. And then when we look at this these 12 to 15-year-olds, Central Oregon is sitting at about a 22.4. Granted, when this data was created, the vaccine had only been eligible for this age group for about 6 weeks. So I'm sure these numbers look much better at this point, or hopefully. And our goal is 42. So we know we've got a lot of work to do across the board. But coming to all of you as the leaders in your organizations is, how do we turn this ship around and really lean into this work? And I know, Justin, you met with Teresa, your team met with Teresa earlier this morning. I know this was a big conversation in the Health Council QIM Ops meeting last Thursday. I think we can do it. Are we going to get 100%? I don't know if we'll get 100%, but we can do better than 50%.
I'd just like to add on to say thanks. You know, this is the first time it feels like it worked. Like, you know, we got a red flag ahead of time. We were able to tie in, and I know we're already tied into you guys' team. My quality director is and everything. I just mean from me, like the leadership perspective. I really enjoyed the call today. We got to lay out our action plan, kind of get it blessed. And I would just suggest everybody take the time to do that and figure out how you're going to reprioritize resources. And in some cases, like on the Well Child, if you have the Epic platform, you might not even need to be human. You know, you can send out through Epic. Yeah. So there are a lot of these strategies where you can automate these things on a routine basis. So if your problem is staffing, there are ways to kind of get around that. And we shared our plan. I just really encourage everyone to do it, because like we get a lot of good feedback from the exchange with Pacific Source, and I think it's really driven us to meet these measures. And so I hope you guys found our action plan acceptable, and we will do everything we can to make it. I would just suggest that this group take this issue up every month. Once you have the action plans, that this become the forum, that if my group doesn't perform, you should feel free to call that out here and hold me accountable for the commitments I made.
So Justin, I really appreciate the effort in the middle of what's been a time of pretty much nonstop effort to respond to everything and then more. In terms of the group that Emily and I co-chair, the QIM work group and the ops group, what I think would be enormously helpful and combat some of the inertia and disheartened energy that we've been feeling lately is to have your, I don't remember how you refer to your person, your quality person, come back to the group and talk about the energy that was breathed back into this effort by you participating, being at the table with them, helping think through some of the problems, working with Pacific Source. I think those are the kinds of stories we need right now. We're getting all the other stories about what we can't do, what we're struggling with, and they're real, and they don't necessarily generate a lot of hope or energy. So we really want to invite, when any members of this group or QIM work group have met with their leadership, and some of you made a plan and are feeling hopeful, bring that back to our group. I think it's inspiring, and I think it gives people ideas. That's the kind of thing we'd like to see more of and invite more of. And we'll get out of the way. Like we want to get out of the way and let people talk about how they're solving problems.
Well, happy to do that. If you'd like, more than willing to have Deb come, and we can just lay out, we put together 7 actions. I think 4 of them you can automate through Epic. 3 of them will be an additional push from my team. But, you know, Summit's built this amazing population health team for this reason, to make sure that patients get the highest quality. And we'd be happy to come and tell you about it.
Yeah, we'd love to have you.
I have a question. One of the struggles, obviously, which was a huge blow, and I know that everybody, you know, from Pacific Source side and everyone felt it when this like vaccine target got dumped on as like contingent upon these, you know, for funding of these QIMs, because that's almost kind of saying that, you know, you need to do everything, and really taking out of the equation this strong resistance that's coming from the other side that we're like banging our heads against, right? So my ask, I guess, at this point would be, if it's possible and I don't even know how this would be the case. Like, what are some things that are working across the country in communities like ours? And you know, so I know that there's been extra funding opportunity for, you know, getting vaccine, access or things like that. There's extra funding for that. I just kind of, you know, I was reading, I remember maybe this past weekend, it was a New York Times editorial or something. And it really talked about how, yes, you know, on one side of the equation, we can kind of all throw up our hands in the air and say, gosh, people are just super resistant. But there are other dynamics at play, and there's kind of numbers behind that, and really creative ways where, from a public health side, where they're doing some really creative work to get the vaccines almost to door. And I, you know, I have no idea if that's going to work. I worry about the safety of those people who have to do that. But I just wonder if, and the reason I'm kind of belaboring on this vaccine point is, one, it's playing a big part in the Quinn's dollars for this year. Two, obviously from a previous conversation and healthcare crisis, you know, the sooner we get people vaccinated, the better handle we'll have on even managing our hospital capacity, et cetera. So I was just wondering if anybody would be willing to do a deeper dive and see if, you know, sleuthing through it, or if you have networks of communities across the country where what kind of programs, what kind of really creative things are even showing some higher uptake, and you know, what we can kind of, how we can wrap ourselves around that. And then the second piece is obviously this from a, I do think there's a huge element of kids not being brought in to see the providers right now, because they don't want to have the vaccine conversation.
Yeah.
They, you know, so I think there are so many barriers right now that are playing into some of these Quinn's outcomes, especially around immunizations and those things.
So Divya, I don't know if this group is aware that we're part of a vaccine confidence coalition, not we, public health. So I can reach out to my public health colleague, Nahad, and just ask him about that and get that information to this group. And yeah.
It's Commissioner Dare, and I have a number from our chart as of August 2nd. I wanted to share that. It's 12 through 17-year-olds vaccinated, and it's 46.8%.
Wow.
So,
big difference.
Yes.
Yeah.
Anyway,
yeah, thank you, Commissioner.
I wanted you guys to know. I thought it was almost 47. Isn't that what you said you were shooting for? 47.4. So we were close.
And Commissioner, is that the number of the general population or just the OH? Okay, because this is just the OHP. Yeah.
Yeah, I
so
know.
it's a little different, but still that's good news. The other thing I was thinking, Divya, is I just read an article too this morning about the Native American community having some of the highest rates of vaccination for all communities of color and marginalized communities. So there may be some communities right here in our backyard who have figured out some important things about how to do this well. And I think we should talk to them, honestly, because I think Rick can weigh in on this, but I think our Warm Springs population has fairly high rates of vaccination as well.
We do. It's 69.1%. So that is actually the highest for our region.
Yeah.
They had a lot of deaths, remember earlier, a lot of elderly people died from COVID, and I think that must have been incredibly impactful for them because they're the highest.
There's a couple of things. IHA does a great job with public health. They don't do such a good job with acute health, but with public health strategies, they're generally ahead of the rest of the region by a long shot. And then two, you do have a culture that was severely impacted, devastated by diseases, and some of them were induced into the population. So that's still part of that culture. So yeah, I think I want to focus our discussion there is, I think, a real ask out of Janice that I think she articulated that this would be a good time for executive leadership in each of the organizations to partner with their quality management. So we're talking to you, Megan. We're talking to St. Charles Outpatient, whomever is the executive in that, to really partner right now with their quality management, because how, as we all know, how the executive spends their time does impact what the organization actually does. So I'm hearing that as an ask. And then we're also hearing that Janice will partner with Deschutes Public Health to bring strategies that we can begin to look at, seeing if we can partner with Deschutes Public Health more broadly and with other health departments to promote vaccine uptakes. So I think those are two action items out of this discussion. Are there other pieces?
One other thing we talked about at finance, because we had the same topic at finance, I wholeheartedly agree where the executive and sometimes the board points the organization goes. But what we had talked about is there also an opportunity, whether it's the QIM work group or ops, to have by organization certain goals that are agreed to, and then there's that oversight and monitoring. I feel like if in the early years we did that, and that might help us in this next runway to make sure that we're either watching us get onto target or looking at how to pivot if we're staying off target. So that was just another discussion we had at finance that could be helpful and additive to the other asks from today. And then from a vaccine perspective, I think it's good to hear what other folks are doing. I also think right now we're getting the hesitant folks, especially with the Delta variant. And in any clinical setting where vaccines can be offered, it's helpful to have everyone offering the COVID vaccine and have it ready if you're in a primary care visit, specialty care visit in the public health system. If you have that conversation and someone says, I'm ready, that you go ahead and get that vaccine. We're seeing quite a bit of uptake with that, I think, because of the Delta variant right now and actually getting more people scheduled. So I think when you have someone in your mix where that's available, that's another strategy to think about as we look at additional efforts that could help our populations.
Okay.
And then Rick, the third ask was if the executives here are aware of cool things that their groups are doing, bring it back to the QIM work group, because that group really needs ideas and energy and creative thought. And that's a great place for it to come back. Those are the people that are going to execute some of this stuff on the ground. So that's the third ask.
Hey, Rick, I just wanted to throw in the real opportunity. Groups are going to be short staffed, so having them outreach for dental, having them outreach for adolescent, or having them outreach for alcohol, having them outreach for all of these things. There's a real opportunity to pair this stuff up around the well-child visit and make an all-out push there. And the groups that have EPIC can use it as a hard stop when that person comes in for whatever the visit is to do a catch-all for all of these things. You just might really want to consider, with only 5 months left and such a big ship to turn around, everybody might want to consider what's the one leveraging point they can get the most bang for the buck from. And that might be really making an all-out push to get the well child in and then do everything else behind it.
Mm-hmm.
Just an idea.
Thanks.
And I think hopefully it's that, everybody knows you have full dedication from the Pacific Source team. Teresa and I will jump into any meeting. Annie Gottfried is the performance coach. We will jump into any meeting, lean in and support, look at plans like Justin's team has made, help endorse them. If QIM Ops is the right forum, we take it back and we start tracking it. We are tracking these metrics not only on a quarterly basis, but also looking at monthly targets and, are we getting closer? Where are we at? And that is being shared again at every QIM ops meeting. And if the board would like me to bring them back and monthly or, you know, in a couple months, we're happy to do that. We'll lean in wherever the team needs us.
Okay, so I heard some concrete actions out of this, and that's good, and some willingness to put executive focus and energy on helping get more energy and focus and ideas into the quality management and workflows at the clinic. Please.
Yeah, and again, obviously defer to ops and their expertise, but my recommendation would be not to have, not to wait even monthly to see outcomes, and perhaps weekly goals of, you know, each organization is responsible for 6, you know, whatever, like some denominator that they have to hit, or of the, you know, or something like that, so that we don't find ourselves in a month not having moved much and then been surprised, and you know, we're next thing you know, we're down to 3 months left or 2 months left.
That is data, and those are points that Teresa and Annie have been sharing with the clinics for quite a few months now. It's what we call the need to treat, how many patients a clinic needs to treat either on a monthly, a weekly, or even a daily basis in order to turn the ship around and get back on track.
So do the clinics,
and I think,
reporting to you weekly then, how many they were able to? I mean, I'm just wondering if there's that kind of an account. Is that what we need to do? I don't know.
Yeah, maybe
I think that's what Megan was saying.
Yes.
Yeah, maybe this group could benefit from just an Excel chart with what the numerator is right now, and then every month as we get together, see that number move by group. I think that would be like really impactful for us to be able to talk to each other if one of the groups can't make it, or is it, you know, maybe there's a way we can help the other groups.
So let me ask a couple questions that may help us get closer here. Andrea, my observation around this particular topic is that it always seems like a surprise to a few members of the QIM or ops work groups that these regular reports are out there. And so I just worry that there's a step that gets dropped somewhere in the handover as people change jobs, or, you know, I'm not sure where it is, but I wonder if there's a way for this group or those in this group who want to receive those to receive them, so that they know that they're coming to their teams and can kind of say, hey, I know you got the report, where are we? Because I wonder if sometimes, I don't know that we—
Actually, that's a great point.
Yeah, I don't know that we can be the designers of the communication loops that need to be in your organization to make this happen.
Right. It makes it important if I go ask for it.
Yeah, yeah. I mean, it's
I'll
the
do
same
that.
for me, right? So,
Good advice. Thank you.
yeah. So is it possible, Andrea, to get those lists to people from this group who put their hand up and say, I'd like to see it for a while? And then if you all tell your folks, here are the targets we want to have, share them with us and we'll check in. We're happy to check in, but we can't set those targets for that group. We're kind of the convener.
Teresa and I can back into some of this work. I mean, we can, based on numerators and denominators, right? We can say where everybody needs to be. And I know, you know, through Donna, we share all of our data. And so if the board wants to start receiving these, I think it'd be easy to ask Donna once, you know, we send them to her, that she forwards them to all of you guys on a monthly basis. I think that would be easily done. Donna, I'm volunteering you.
And then the only other thought I had was, and I don't want to get in the way of momentum. I don't know that the community is going to get to all of these. So making some group decisions about the ones where there's a real possibility, so that we're kind of all pulling together versus each pulling in a certain direction, may be helpful. And it may be helpful not just from a strategic perspective, but also from a staff morale perspective, because I know my people are very, very tired. And if I give them 6 things to focus on, plus, we're going to lose ground. If I say, if we can just get to these 3, we really can earn some additional revenue and really address some critical health needs in the community, that's a different conversation. So
sorry, Janice, I'm jumping in because I want to say, I would really suggest that our strategy be, we focus on these 3 measures with the stars.
Yeah.
They are our challenge pool metrics. They also have some of the smallest, I guess, gap to goals to get us back on target.
Is that a new term?
Sure. But if we were to meet these and we're securely meeting this DHS 60 metric, those are our forward challenge pool metrics. And again, there's some real money that can be earned back if we meet these metrics, even if that only puts us at 80%. If the other, 14 or even 10 CCOs are struggling, there's going to be money left on the table, and that can easily bump us to 100 or way over 100 like we've seen in years past. So that would be my strategy. We focus on the 4 challenge pool metrics.
Okay, good, thank you. I think we have action plans out of that, and that's useful. I'm trying to respect time and move us forward. And
thank you all.
Just to say on the alcohol and drug, recruiting for drug and alcohol counselors turns out to be harder than recruiting for nurses. We hire both. Just saying. Funny shortages out there. So Leslie, I wanted to give you time now that we need to say, oh, Ms. Neugebauer, need to give you time.
Thank you. I'll be super quick. 1 second. Okay. You've seen this before. Oh, you can hear me, yes? Okay.
Yes.
You've seen this before. These are annual CCO performance metrics. It's always great when you get off mute. Excuse me. These are the Q2 updates. So you've seen, this is a newer version of this document. So you saw this in Q1. Now we have the 2 quarters of experience there. Just to orient you, the notes are just for Q2 only. So you can reference the update I gave back in May for Q1 if you want to see those notes and make those differences. This is really just a real estate issue of trying to get it on one page. I won't belabor the quality incentive measures. Of course, we just talked about that, but that's why that's in red. I'll jump to the transformation and quality strategy here. That's in yellow. This is really just a yellow because we didn't get an A+ on our scores from OHA, but scored higher than the average score of all CCOs in the state. And the feedback there is that 3 of the projects for our 2021 transformation and quality strategy plan just needed some kind of shoring up on a couple of improvement opportunities for some of the plans for this year. So we plan to, or we're already working with some internal project leads on that. Excuse me, and incorporating those changes for our projects moving forward in 2022, and you'll hear more about that later this year. Just going to move down here for points of interest on share initiative funding. So this is a new funding stream for CCO 2.0 that if a CCO has a profit at the end of the year or a surplus at the end of the year, they have to reinvest a portion of that into the community. So we did have that in Central Oregon. It's the portion is about $58,000. Our community health coordinator in Central Oregon, Kristen Tobias, is working with CAC and many others to implement the FUSE program using these dollars. So you can read more about that there. It's really about increasing the ability for emergency housing vouchers and increasing their program around some housing supports there as well. I'll just move down to some points of interest here. There's another yellow mark here. This is just showing that the all-cause hospital readmission rate is kind of trending in a upward, in a downward. No, it's up. It's supposed to be down. Sorry, this is an inverse metric. So just a little bit over the target. This was just a flag and make sure that folks are aware. I think typically in quarter one, we don't see kind of the trend here until later in quarter two and later in the year. So we'll keep an eye on that for the next quarter as well. And then just one other point I wanted to make here around some access and some health equity pieces. We did launch, we did launch a new member access to care survey. And so that metric for this particular operations section has been met. So pleased about that. We'll have some results later in the year. And then also met this metric here around being able to have some internal capabilities to incorporate real D data into our grievances and appeals information. And so being able to stratify that information so that we're able to understand more about trends for individuals in the BIPOC community and other, marginalized communities. So those are really the high points. You can of course look at this in your packet. It's on page 13. I'm happy to answer any questions now or at a later date.
Any questions for Leslie? So I'm very much aware that we're running over time, and that ruins my reputation for ending meetings early. But Donna had a couple of other connections. I think for Miguel, instead of shafting you your time, I would ask that we allow some time at another month to appropriately give you all the time that you're asking for. Otherwise, you'll get 5 minutes instead of 20. Okay, thank you. So Donna.
Yep, thank you. Thank you, everybody, for great dialogue today. Just a couple of things. The survey results are in, and they will be released on August 19th. The board will receive their responses. CAC will receive their responses, with the exception of Brad and Linda will actually see both sides of that, since they sit on the CAC as well. There will be an agenda with a little bit of homework, really just 3 little quick survey questions in there for the September 9th combined meeting. There was some great input and insights. I really appreciate how much effort everybody put into actually completing those surveys. 2, Senate Bill 741 has been signed by the governor, and as they say, it is in the book. So that is behind us. Another probably fairly big milestone is that the Health Council staff has moved from the COPA clinic in Northwest Crossing over to an administrative building on MK by the mill. A significantly smaller space. As you'll recall, we did transition the older adult behavioral health initiative over to Pacific Source, and that was effective on the 9th of August, which was just this Monday. And that transition is complete now. So we had 2 staff members that were no longer needing space, but we are working with Brad to partner on some community space on the east side. We're pretty excited about that. More to come. And then the only other thing I wanted to mention is that the Connect Oregon pilot has also successfully transitioned with a bow on it over to Pacific Source as of August 3rd. And we will now migrate into the Jefferson and Crook counties as well as Deschutes. And I got to tell you, the uptake on that is really great. And just really appreciate the team at Pacific Source and how they really wrap their arms around this for the community. And it looks like it's going to go really well. So please know that the Health Council is actually remaining in an advisory capacity with the state around how to continue to spread and scale up the Unite Us or Connect Oregon platform. Okay, there was my speed speaking.
Okay, I do want to appreciate everyone hanging in there and having some pretty meaty and uncomfortable discussions and being willing to engage in those and work toward mutual solutions for the good of the community. And hard meeting, but useful. And so that's why I let it go a bit long. Any other comments or questions before I head toward closing this meeting?
Be on the
Yes,
lookout
Rick.
for party invitations all.
I just wanted to acknowledge your leadership and your guidance and stewardship through this meeting, Rick. I know it was a challenge and who knew where it was going to go, and you've done a masterful job. Thank you.
I just have to say, compared to mathematics, you guys are easy. So just saying.
Thank you, Rick, for giving us exactly what the line is. So.
High bars here. So
Awesome.
any other questions or comments? Okay, can I hear a motion to close?
So moved.
Second. Okay, all in favor, say aye.
Aye.
Thank you, folks. Good meeting.